Kavish?
Hello, yes, sir.
Hello.
Good afternoon.
Yeah, afternoon. Finally, I connected. So let me check if let me check the slide if they can be shared.
So should I stop sharing?
1 second, yeah. Just show me. I'll connect and then see because today I had a lot of problem in connecting.
Okay.
Hi Padma. I think you got in.
Morning.
Yeah, morning. Good to see you. Night and morning. It's so pleasant.
Night and morning. I know. Raining webinar. It actually rained so badly in the morning today. Yeah.
Oh, Mirage or whatever is flying over us. So that was fantastic.
Yeah. Fly past.
Mansi, can you check? If you unshare, deshare, then I will just check and then disconnect. Yeah. Fine, it is. Okay. I'll just check. Just see that if, yeah, video is also on. Perfect. I'll stop sharing, Mansi.
Yes, sir.
Yeah. You can have your,
So are you going to show any videos?
That's okay. It's a very small video. It is shown already.
Yeah, okay.
I could see that.
No,
No,
but
it's okay.
can you play that video and check once?
It's okay, Mansi.
Okay, all right.
That's perfectly all right. No problem.
No, but anything, nothing is coming. Advanced.
Hello. Can you hear me, sir?
Yeah, I can.
Yes, sir. This is Dr. Mansi here.
Yes, Mansi,
ANT.
are you seeing me?
Yes, sir.
Are you able to see my video?
Yes, I'm able to see you. Can you tell me what is it that you can see on the screen? I think you're facing.
Nothing. I'm not able to see anything. Bhavesh Thakkar only I'm seeing there on the other side. Otherwise, I'm not seeing anybody else.
Okay, but can you see the screen that is being shared, sir?
No.
You can't
No.
see anything.
No.
Okay.
No.
Right. So what we can do is
Can't see that.
This must be a bit slow right now.
so you are only able to see it's written.
Bhavesh Thakkar I'm seeing,
Okay.
and I'm not seeing anybody else.
No, but can you see what is being shared there? I have put this up webinar on TeleNeurology. All the
No. On the back it is there. But shall I minimize this and then see that?
Let me see a view of
Webinar you are seeing? Are you now? I'm seeing the webinar that this one and Bhavesh Thakkar.
Yes. So you
But
can
I'm
see
not
that.
seeing
Right?
myself.
No, that is okay. So when you can see it is written Bhavesh Thakkar, on top of that there will be 3 icons. One is a minus icon, one is a rectangle, and one are 2 small squares.
Nothing is seen here. It is
Yes.
blank. It is blank.
No.
Above Bhavesh Thakkar, there is nothing there.
Oh, so you're using a Mac machine, sir?
No.
An Apple
I'm not.
laptop?
No. Word only, MS. Not Apple. I'm not seeing anything except Bhavesh Thakkar and webinar in TeleNeurology.
Okay, all right. So on top of where you are seeing Bhavesh Thakkar, above that,
Nothing is there.
can you
Blank.
see something like gallery view?
No, nothing is there. It is
Right at the top, sir. Right at the top. Above Bhavesh Thakkar, but right at the top.
Only it comes as Bhavesh Thakkar view options.
Yes, so options. You can select those 3 dots.
Video panel is there. Hide video panel.
Yes, video panel. Yes, you say video panel.
No. Hide video panel was there. Hello.
Yes, sir.
But if you say show video panel,
yes,
except Bhavesh Thakkar, nothing else comes in. I'm seeing your now Padma Srivatsa has come.
Yes.
Hello Padma.
Morning, sir.
Morning. How are you?
I'm doing good. I can see you.
Okay. I can see you, only nobody else. That is the problem.
Okay.
I was seeing only Bhavesh, and after that I'm seeing you now.
Okay,
You
so
are missing me then.
Yeah, nobody else. I see
so
only.
sir, on top, in that video panel, on top, what name do you see?
You here it says that you are viewing Bhavesh Thakkar's screen.
No.
And view options.
Where you can see Dr. Padma.
Nobody else. Now there are 3 stars. Yes, 3 boxes are there.
Okay.
Yeah.
So you can
now
see
Bhavesh Thakkar is there. The blue box is there now.
Yes. Okay. So now beside that blue box, do you have those 2 small squares also?
Yes, it is there.
Click that, sir.
Okay. Now it has come.
Yes.
Now it has come. I am seeing Nirmal Surya now.
Yes. So now and below that. So now as people join, as panelists join in, the box that you are seeing, if you are seeing.
Morning, sir.
Good morning. How are you, Nirmal?
I'm very well, thank you. Good to see you, sir.
Yeah, good to see you.
I'm very good, sir.
Okay, fine.
I'm always proactive, sir.
Very nice. Always proactive. That's very good. Good to hear that. Anything else, Mansi?
So when you face a problem, we will see.
Okay. What's your number?
My phone number.
Yeah.
Okay, it's 89.
By chance, if it is required,
Yes,
I
yes, sir.
will.
Yes.
I will store it 1 minute. You tell me.
8956
Okay.
40
Okay.
85
Okay.
00.
Okay. I'll just give my missed call.
Yes, sir.
Okay. That is my number. Okay.
Yes, sir, I got it.
Okay.
Thank you.
Good morning, everybody.
Hi, Sumit.
Oh, Sumit, how are you?
Good morning, Sumit.
I'm good, ma'am. Am I audible?
Yeah, you're audible.
So actually, it will be better if you close the curtain because that light behind.
Okay.
Yes.
Mansi,
Yes, sir.
can you
Is it
resend
better?
email to Professor Madhusudan?
Yes, sir. I'll do that. Sir, I've sent the link to Dr. Madhusudan.
Thank you.
Dr. Prabhakar is joining us.
Yes, sir. Prabhakar is coming in no time. He said he came, but there was no one, so he went back and now he's rejoining.
Hello.
Hi.
Morning, sir.
Hi. Good morning.
Manjip, Dr.
Hello.
Prabhakar, video
Hello,
on.
Dr. Padma.
Morning, sir, but I can't see you. Where are you?
Yeah, I can't also see you, Prabhakar.
So where you have the entire video panel, below that there'll be an arrow. So all of you all will be able to move down to see more panelists.
Yes. Hi, Prabhakar.
Hello.
I can see you, Prabhakar. Good morning.
Hello.
Good morning.
Good morning, Prabhakar.
Hi.
Hello. Hello.
Hello.
Hello, Gagan.
Pramod, I'm seeing now.
Yeah, I'm seeing you, sir. I can see you.
Yes. Hello. Good morning,
Hi,
Pramod.
Pramod.
Hi.
Good morning,
How are
Pramod.
you?
I can see Pramod.
Yes, sir.
Morning,
Uh,
Good
sir.
afternoon.
Now I can see.
Oh,
Yes. Good.
morning to everybody.
Good morning, sir.
Morning.
Afternoon, हो गया अभी?
Afternoon, ho
Yeah.
gaya.
Morning.
It is not yet afternoon. It is
Morning,
relatively
Good
late.
morning. Hello.
Yes,
Hi.
Gagan. Hi, Gagan. Good morning.
Hello.
How are you?
Good morning. Very well, sir. Very well. Hi, Dr. Padma. Hi, Nirmal. Hi, Sumit.
Good morning, sir.
Yes, sir.
So all set?
So far, so good.
Good.
Waiting for people to join in now.
Yeah.
गगन कैसे हो?
ठीक आप बताओ सर.
बढ़िया.
I think people have to now get back to work and
On Monday.
Unless you are in a containment zone.
Yeah.
Or you are 72 or 3.
Now it is relaxed down to 55.
We are not in containment zone.
We are in containment zone. I think the virus are
We are in the red zone,
Yes,
sir.
Sandra, not, yeah, correct.
Containment
no,
zone,
we
red
have
zone.
to.
Red zone is further divided into containment zone now.
We are in containment zone in the red zone.
Yeah. You are in the red zone, correct. Nirmal has to be inside the house.
No, sir, I go to the hospital. I'm working. I've been very actively involved with the government of Maharashtra.
Uh-huh.
2 days ago, I arranged 1,000 PPE and gave it to our young Aditya Thackeray for using at NSCI Dome and Podar Hospital, which are in our constituency. NSCI, we have 1,000 beds. So we are admitting COVID suspected patient there. And Podar Hospital is also having 300 beds. So I'm not directly going into hospital, but I'm working, sir. And G South, we had about 780 patients till yesterday, out of which 63 got better, 13 deaths we had. So that's our Bombay G South area. But we have developed the Kolivada, which is completely containment free. So now this model has been followed in whole Maharashtra. 13 cases in first setting. We got 5 more minutes, and I think Professor Madhusudan said his house light is gone, so he's trying to connect through the mobile phone. I hope he get connected. The only Ghosh is not joined, so I'll ask him where he is.
Who's left?
Hi, Biplab.
Hi, ma'am. Good morning.
Back again.
Yeah, we are back again. So it was wonderful. Yesterday you had a stroke at that time. I mean, like
Yeah, and there's another stroke which is just coming. So I agree with what was being said yesterday. Dheeraj was saying that now we are seeing more. We had this lean period of 30-40% down, and suddenly they're again starting to come.
Right.
I don't know why. Maybe lockdown is eased out a bit. I have no idea. God knows. So there's
Hi, sir.
one coming now.
Prabhakar sir, good morning, sir.
Good morning.
Satish sir, good morning,
Good
sir.
morning, Biplab. How are you?
Fine, sir. Fine, sir.
Good to see you.
It's a pleasure, sir.
Though we are far away, but we can see in our rooms now. So nice to have that privilege to see. That's good.
Galandhi, sir, good morning. It's a really great pleasure to be with you all, sir. It's a really.
Yeah. No, it's
pleasure
Sunday
to
and.
Hi, Dheeraj.
Hi, good morning, sir. Good morning, everyone.
Hi, Dheeraj. Dheeraj.
Dheeraj. Good morning.
Hi, we meet again.
Good morning.
Morning, sir.
Morning, Dheeraj. How are you?
I'm good. I'm good.
Where did you get the haircut from?
He's looking so bright.
It's about to get into a pony right now.
Okay.
I'll have a pony very soon.
So my son could not access. He's not like me, no. So he did it himself only a few days back.
So I think we're going to see a lot of ponytails very soon.
I think it's opening up from tomorrow that some of the salons will be opening up.
No salons. No saloons at least.
No saloon, no
Standalone
barber shop.
salons are opening. In Gurgaon, standalone salons
In Gurgaon, maybe,
Gurgaon
but that's, I think,
zone. So, mate,
Yeah,
you're
that's
in
the
orange
reason.
zone.
Yes.
You're orange zone, so your barber shops and salons should be
So,
open.
but the barber shop actually is going to be one of the most risky areas where
difficult
people
one.
collect together.
I agree. I agree.
Hello.
Okay, yeah.
Hello. Hello.
Ideally, a training process should be, rolled out for all these shops. They won't be used to. They can train them, which I think they will, because the way the things are moving so organized. They might train these people.
Yeah.
Auntie, can you speak to Dr. Lakshmi and see if he has some difficulty? He logged in and he logged out.
Lakshmi, I'll give him a call.
I'll talk to him, sir. No problem.
Good morning, sir, Dr. Prabhakar. Good morning.
You are looking changed. He'll just give you a call. He'll. Bhavesh, can you call Lakshmi? He is unable to log in.
I have just called him. I have just dialed him.
So Arindam, he's also not been able to connect. So these two people just called because we are now almost 1 minute left.
So the clinical neurophysiology group, they have come up with some guidelines and recommendations. So Dr. Mansukhani and Dr. Gauri Devi, Matthew Alexander. So I think by tomorrow their document would be ready, and we'll circulate it across to all members by tomorrow and day after. So I think that's important, because this is about the time when across the country most EEG labs, EEGs and EMGs were almost closed completely till about, but now the general mood is that all labs should start getting back to work. So they will have the document ready by tomorrow. So we'll just circulate it across to all members. So
what document, sir?
The news.
Can you hear me, sir? Good morning.
Can you? Yeah.
Right.
Good morning, sir.
Good morning, Madhu.
Can you hear me?
Yeah, Lakshmi is also there.
Good morning.
Good morning, Lakshmi.
Lakshmi is in an orbit.
Yes.
Lakshmi is in orbit.
Seems to be.
We got full house here now. Ragan.
Yeah.
Everybody is here.
So I'll request this teleneurology thing has been basically Nirmal's idea, and he's been working very hard over the last few days to organize something. I think it is extremely important, relevant, and very timely. I would request Dr. Nirmal Surya to take over from here, introduce the subject. After that, Dr. Pramod would have a few important announcements, and then we can go on with the program. So, Dr. Surya, please. Thank you so much.
Thank you, Dr. Gagan, and thank you, Professor Pramod Paul, the President of Indian Academy of Neurology and Secretary of Indian Academy of Neurology, to having invited me to take this important issue today, which is very important. And I will go through certain part, a 5-minute PowerPoint presentation. Before that, I want to welcome the chairperson, Professor Satish Chandra, the past president, and Professor Prabhakar from Chandigarh, and Professor Satish Chandra from Bangalore. Both are past president of Indian Academy of Neurology. And the other speakers, Professor M.B. Padma from AIMS, Professor Lakshmi Narsingham from Chennai, Professor Madhusudan from Chennai, Dr. Sumit Singh from Gurgaon, and Pankaj Sidhu, who is an IT champion, who are the speakers. And then the panelist, Dr. P.K. Shetty, Dheeraj Khurana, Shetty from Delhi, Dheeraj Khurana from Chandigarh, and Arvindam Ghosh from Kolkata, and Viplab Das again from Delhi. So we have 14 people here in all to take teleneurology into a big. So can I share my presentation? I'll just give a brief overview for just 5 minutes. All right. So going to the TeleNeurology webinar, am I seen the screen now?
Yes, sir. Yes,
Hello?
sir.
Yes, sir.
Yes.
Yes, loud and clear, sir.
Okay. So next 90 minutes, this is COVID pandemic, medicine, a new normal, low ratio of neuro per 1 lakh population. So these are some of the issues which are going to come. And the context and key question today are less than 5,000 neuro to serve 1.35 billion people. Does technology have a role to improve medical care reach? How can we effectively manage patient diagnosis, treatment, and home-based medical care from a distance location where we are? Can neurology specify universal technology platform be built with well-defined process flow? So we need to connect all the dots together. And that's why this meeting today, where so many people are there, we are trying to connect all the dots into a proper framework. So what would be a good teleneurology, and how does it should look? So there should be neurology specific telemedicine platform, which should be easy adoption method, easy appointment access for patient and doctor, option of audio, video, text facility, payment gateway, compliant record keeping, and technically platform built in compliance with guidelines. We also need well-defined flow of tele-assessment, and that should be accepted list of neurological examination, disease-wise, standardized and accepted method of non-physical assessment of patient from distant location, that sensory and motor examination, which my colleagues are going to explain us in detail, and standardized way of data recording on tele-treatment. And then of course, effective treatment and monitoring. So online treatment, either handwritten or computer generated. So that prescription has to go, facilitating online diagnostic or medicine supply, and good data analytic to improve treatment outcome, and data analytic promoting studies, and of course the publication and research. So this will be a good telemedicine framework, and that is easy appointment booking, online app based, telemedicine mode selection, audio, video, text, payment, fees collection, and appointment of confirmation and time schedule. So that's 4. And then tele assessment of patient, information exchange and report sharing, provisional diagnosis and treatment advice, and treatment submission for e-treatment prescription for patient. And then patient education and personalized infrastructure, follow-up visit remedies, good data record keeping, compliance and safeguard against medical legal case. So that's about this, but I want to give you that we started teleneuro rehabilitation much before, and this was the first international congress in teleneuro rehabilitation, which was last year May, where I was one of the international speakers to talk about opportunities, problems, and policies of teleneuro rehabilitation in India. So what was that time was thought that tele-rehabilitation is the solution because of these problems what we have. And mind you, this was before COVID, that is 2020 BC, as Padma yesterday said, before COVID. So these were some of the issues. And we highlighted that number of smartphones in India are going to be double by 2020. So about 900 million. And if you look at average mobile data consumption per month in India was about 80 gigabyte from 2017 to 2022 was very high. And if you look online video consumption in India slated to rise, and I think this 22 data may be valid even today in non-COVID, where use of internet data is quite high. So what are the subfields we divided that time in tele-rehab, tele-consultation, tele-multimodal care, tele-health care, tele-home-based care, tele-technology-aided rehabilitation. And mind you that India was leader. And if you look at the telemedicine for the temples was developed in 2018 for this Kumbh, for Chardham Yatra, they have developed this telemedicine center. But neurodisability care in epilepsy patient using multidisciplinary tele-rehabilitation was a pilot study which we started in 2019, which was a single group study for total epilepsy care in rural district of Maharashtra. And that was to study the feasibility and effectiveness of multidisciplinary tele-rehab on neurodisability seen in epilepsy patient. We evaluated the burden of tele-rehabilitation on caregiver, and we also had patients with mild to moderate disability with a smartphone who visited the camp in rural district of Maharashtra, not taking any rehabilitation. They were the one who recruited in this study. And this was the eligible assessment. There was exclusion criteria. There was baseline assessment from neurologists, therapists, occupational therapists. This was before we could see them. And then there was goal formation by multidisciplinary team, recording of intervention given by patient, given to the patient by caregiver. Each intervention is tailor-made. And then intervention to be given 1 hour per day, 5 days a week, 1 month under supervision, and without aid of caregiver, outcome assessment by 1 month, and outcome assessment by multidisciplinary time by post 3 months. So these are some of the things which we did for the occupation therapy protocol. And this is the patient who has been assessed speech therapist on the tele-rehab from the hospital. And these were the 13 patients. We had 8 male out of these 13 patients, and the age was 16.1 year. And these were some of the issues which were seen in these patients with the epilepsy. And we followed them for 1 month, and there was 80% compliance on the tele-neuro rehab, and the 50% patient did complete task, and the 30% patient did partial task, 20% did not do it. And then we checked the mean pre-Barthel score was 52, which improved to 59 in 1 month. And pre-Jared caregiver burden inventory score, which was 38 when we started the treatment, increased to 39.6. So caregiver burden definitely increased in this study. And we did also FIM scale, which was 97, improved to 103.9 in 1 month. So these preliminary data reports suggest that tele-rehabilitation achieves comparable restoration of daily activity of living without putting much burden on the caregiver, which was very small, 1 point. An improvement of motor improvement post tele-rehab suggests that the gap between the demand and supply of neuro rehab services will be bridged. So this suggests that this could be a definite mode for the future in this country. And I think with this background, we have got now more opportunity with the coming of COVID, that we are now able to reach to more patients with this tele-neurology. And I keep this subject open, and I pass on to 2 chairperson to take it further. Thank you very much.
Dr. Satish Chandra, sir, your mic is muted, sir.
Professor Prabhakar and Professor Satish Chandra.
Please.
Professor Satish Chandra, you start.
Yeah, good morning, and thank you, Nirmal, for giving this opportunity to all of us to participate in this IAN teleneurology. And just to go back a little bit, in 2014, when I was heading the institute, we started what is known as YKN, Knowledge Network. And from the Knowledge Network, we were starting the sessions all over the country, and we were using that, which has been upgraded now in NIMHANS as a knowledge academy. That this will become very useful one day. And after about 6 years, because we are in a difficult time now where we cannot see each other and we cannot talk to each other in person, this is the only way we can go about it. And that is the reason now we are having this teleconsultation. And we are all aware of teleconsultation. We were doing teleconsultation and video consultation. But there is a problem. The problem is with regard to the neurology. We always feel the neurologist need to examine in detail. The neurologist has to do a motor examination, sensory examination, and how do we examine the cranial nerve? These are the difficult issues which other physicians may not be doing in day in and day out. And that is the reason teleneurology is extremely important. I'm very happy that Indian Academy of Neurology is organizing a teleneurology symposium today, and we have the experts to talk about the various issues, how to go about the examination method through the tele mode. And that's the reason we are assembling today. I think I will give the mic to Dr. Prabhakar to say a few words so that we can listen to teleneurology. Prabhakar.
Thank you, Sri Chandra. I think this topic is good not only in this period of COVID-19, but otherwise also. At PGI, there is a Department of Telemedicine and remote areas of Himachal, Punjab, they are being advised, the CPC is being done. But however, what more needs to be done is that this needs to be given to the people in the rural areas. And what I have been managing with patients in the last 1 month on teleneurology, I have found problems, and we will discuss as the time passes on. People do not have 40% of the patients in the rural Rajasthan, rural UP, Punjab, Haryana, they are not having net with them. And I start with the video call, but then I have to shift to the routine telephone call. So that is what is happening. I think this matter also needs to be considered. This is a good topic. And as Tish said, we have to look into how to examine a new patient when, and this is we are going to do today. Okay, then we'll pass on to Tish for going further.
Yeah, I think we will start the first talk now, and we will go in for the I think the mic can be passed on to the first speaker and to yeah. I think we can.
Can we start, sir?
Yeah, please, Lakshmi Narasimhan. I don't
Yes,
think we need introduction for Lakshmi Narasimhan. Lakshmi Narasimhan is very well known to the neurologists in the country and outside the country. He is very
sir,
much
I think
interested
Dr. Padma has to speak first, sir.
Okay. Padma? Yeah. Padma Srivatsav. Padma Srivatsav, mic to be given to Padma Srivatsav.
Yes,
Before that,
yes.
I just say a few words about Padma. Padma, Professor of Neurology from All India Institute of Medical Sciences, with area of interest being stroke and epilepsy and also demyelinating disorders. I don't think she needs introduction for this focused audience of Indian neurology. And today, she is going to talk on teleneurology and examination. Padma, please go ahead.
Thank you, sir. And thank you, Nirmal. Thank you, Gagan, Pramod. And so it's great to connect with you and Professor Prabhakar. It's wonderful to see you. Well, I will share, I think this is where I share. Yeah, have they come on?
Not yet.
Yes,
Not
they're coming.
Yeah, now it has come.
Shall I go ahead? I think I don't think this is full screen, but yeah. Yes. Okay. So, so you'll all agree with me that it's raining webinars. So we've been actually having back-to-back, these topics, and part of the telemedicine and teleneurology and telestroke, in fact, has been covered in numerous portals over the last couple of weeks. And well, talking about the COVID era and the corona will be like carrying coal to the Newcastle. So we're all, I guess, in an era where you should, as Nirmal said, it is BC is no longer before Christ, it will be before corona. And then, so it'll be like 2020 BC, and maybe 2021 or 22 will be after Corona. So we probably have to redefine the entire, the way the timeline of a universe. So that big an episode, we're going through it. No wonder we will be talking more of the redefining the existence and a new normal, where the virtual learning, virtual treating, virtual surgery, virtual therapy, virtually everything in our own space with some distancing will probably become a new normal. Said that, telemedicine again is not new. So the use of telecommunication has been in vogue probably again for last almost more than 50 years now, in form of connecting with someone over a period of distance. And this used to be simple telephones. And then of course we have the further advances, and we're probably hearing much more about it by the IT experts. And this has become truly virtual, in the sense that we can perform even virtual surgeries. So it is that kind of an advancement and using technology. In fact, one of my colleagues had said that using this humongous advances in technology is a force multiplier. So when you say it's a force multiplier, is that you're having your entire infrastructure and personnel, in our terms medical personnel, being multiplied into a big force using this technology when we have the dearth of all these things existing. So, and this is such an era going on. And the objectives of telemedicine is health for all. This is a no-brainer, no rocket science to understand that health ultimately is not a luxury. It can't be bartered amongst haves and have nots, and it is my birthright. And any civilized society has to make sure that you have optimal healthcare, be accessible, available, and affordable to everybody, every citizen in that society. And it has to be ingrained into a societal fabric. So health is my birthright. So therefore, to be able to deliver this kind of optimal healthcare across the social, demographic, and geographic, economic barriers across any country, any society in this world, has been the cornerstone of the concept of telemedicine. And of course, built into it would be saving time. And in neurology, we have a whole lot happening where time is brain, not just stroke. We have a whole lot of other things where time is brain. So transporting a patient across a period of time and distance will need time, and you're saving that time. And of course, there's a tremendous decrease in costs of medical care. Just take our webinars, for example. Trying to organize this in person versus on a webinar is probably there is a huge difference in terms of economics. So these are all no-brainers again, and which are instinctively and intuitively understood by everybody. And in India's scenario, it's certainly not an option. It's a mandatory necessity. It is absolutely essential. It is paramount important that it gets ingrained into the basis or the fabric of a healthcare system, even beyond the era of COVID. Because we do have a hierarchy. We do have a three-tier system. We have a primary, secondary, and the tertiary care. Our tertiary care facilities, you will all agree with me, they actually are even better in some of the best care facilities in the developed world. They compete with the best. But then, as Professor Prabhakar has pointed out, in the interiors, in the Timbuktu of the Indian society, where it's completely inside populations, there is a very low penetration of optimal healthcare services, be it whether you're talking about ASHA workers or primary health facilities or wellness clinic, whatever you may have, a term for these facilities, they're not optimal. And 90% facilities are there in the metropolitan cities, which are now are all containment and red zones. And so telemedicine becomes a necessity. It is not an option for our part of the world, at least. So, and it is a great promise that it would take this modern healthcare to remote areas using the information technology. And there's a lot of beefing up of information technology, which becomes, of course, absolutely essential, as Professor Prabhakar said. You may have, again, an audio, but you may not have the bandwidth or the kind of space to load in the, virtually being able to see images or conference through a video. And but then this is also has a role, definitive role in training in the education modules. And as Nirmal pointed out, it is a decrease in price and complexity of this whole thing, which makes it economically viable. Thankfully, India is an IT hub, and that's where probably we are much more poised to get this into the midst of our stream as compared to maybe other developing countries. So I think the best example is a stroke management when you're talking of telemedicine and teleneurology. So we call it the telestroke, as you all are well aware of this. And this does address the problem of insufficient numbers of, I meant here, stroke specialists and not neurologists per se. Neurologists are dismally few. And stroke specialists, in spite of training the physicians who are often the first contact, they are dismally few. We in fact don't even have an integrated system to train a physician as a stroke specialist. We all use our jugaad methods, which fortunately are still working. But if somebody goes to a court, there's nothing really to help us out in that regard, because we don't have a real certification process to say this physician is a stroke specialist or a stroke physician. There's an extremely narrow therapeutic time window for thrombolysis or other reperfusion strategies. So we need to have some teleconsult which can go instantaneously, be able to make this diagnosis remotely, expediently, as well as optimally, and allow the application of those standard operating protocols and those procedures and those guidelines which have already been trained in this network. We in fact I'll just present 5 minutes of our experience on this, as well as what we are currently doing in this COVID area. Of course, this also opens up the research paradigms across the nationwide network. So initially, when we thought about telestroke way back in the year 2010, 2011 and 12, and we were in communication with the Ministry of Health, and we were trying to come out with proposed solutions, we thought of a nationwide helpline number. We just fell flat, because even if we have specific numbers which I know are viable in, say, PGI Chandigarh and some other areas, and certainly the hub and spoke wheels in the private sectors, the nationwide helpline didn't work out for a large number of major public health institutes, again because of the simple problems in logistics of maintaining that. The swift and well-equipped ambulance services now have become a reality in a lot of states, and I'm hopeful it will be pan-India. And this hub and spoke models of the wheels have been created. We initially thought the Indian Stroke Association could oversee the endorsement. Didn't really work out that way. But yes, it at least in an unofficial level, it is still, there's a lot of hand holding which is going on. And we've had the proof of principal pilot projects done. And this has been, all these recommendations for kickstarting Telestroke India has gone in. So what has happened subsequently, using simple telestroke models, we've defined these spokes and defined the hubs. Spokes was simple. You definitely needed a CT scan, because the CT becomes mandatory to be able to distinguish. There's nothing else clinically which you can distinguish between a bleed and ischemia. And you needed somebody who could respond and correspond to the hub, but that becomes mandatory. And the standard operating protocols, education, and being certified for those became mandatory. The lab services remained simple point of care systems, which is basically just glucose setting and a blood pressure monitoring. So simple things to call it a spoke, and a hub required everything else that a tertiary care institute would have. So these education modules, remote certification in terms of NIHSS and MRS are already on. All of us do get certified, and we get these booster certifications every year. Taking this NIHSS and MRS, they've been there. And such similar things could also be developed, which are India-centric. We did do this. and we try to do at least in some parts of the states. And well, we'll come to that a little later. We started this in Himachal. Now it's an old story with 10 districts which had these CT scan facilities available, and they were called the primary stroke centers, were handheld by two of the tertiary care centers, which is in Shimla and Tanda. And this was launched in state of Himachal in April 2014, and they were all physicians. And the basic concept was, using this telestroke module, if there is a physician who's manning an emergency, and an emergency is that they're manning fevers, they're manning deliveries, they're manning simple trauma, they're manning heart attacks, so why not brain attacks? It was again a no-brainer. So you had this SOPs, which we call it as monkey-proof SOPs. The workshops were given. It was mandatory to give the thrombolytic drug there on the shelf, which was free, hand holding. And what did we use? We again use a WhatsApp-based, the tele-stroke communication, which we communicated with these 12 district hospitals. And lo and behold, we actually have found the way the primary stroke centers took off. It was very, very heartening to see that the first case of an acute ischemic stroke, which got thrombolized remotely using a telestroke or WhatsApp model, was by an orthopedician who was manning the emergency. So it is so heartening to see these kind of real lifetime experience and real life stories. And well, this we publish, and then has been taken in by Punjab. It is Dheeraj and Jairaj who've been spearheading it. Shalja's taken up in Kerala. Now Srijitesh is very active in the state of Karnataka. In Madhya Pradesh, Niren is doing, and all across the country, they've been really, really, we've had the stroke ambassadors, the stroke champions who are spearheading it. In Uttar Pradesh, you won't believe it, the small little district of Rai Bareli is actually thrombolized about 26 cases, and that's a simple physician sitting there, and this is just by tele-stroke model. So we know that we are facing a dual challenge, and therefore it requires a dual challenge is a double whammy. We always thought that, okay, the communicable disorders are going, it's the NCDs which are taken the country by the storm. We've had the publication in Lancet Neurology in 2017 November by all these, the ICMR, the Ministry of Health, and CHFI, the World Metrics, and say that 56% to 60% of all deaths are because of the non-communicable disorders. And then we now are suddenly hit by a infective epidemic, so a pandemic. So these are the countries which are facing this double whammy, and India is in the midst of it all. So we need these SOPs and protocols which have to be modified accordingly. Time saved is absolutely essential, and the telestroke will deal with this. And this is just to drive home the point that time is such a critical point in managing these patients. And when you're decreasing the door to needle efforts amongst everything, telemedicine stands out when you don't have a neurologist as available. And the entire component of a stroke chain survival, from the diagnosis to the treatment to a stroke unit care, stroke nursing, the rehabilitation so beautifully brought out by Nirmal, and training, education modules, your discharge, the plan, and the monitoring for a stroke recurrence. Every component of the stroke chain of survival can be dealt with using the telemedicine and teleneurology. So telestroke can become the cornerstone in any system, whether it's developed or developing, when we are actually reinventing or inventing now a new normal, because for us in this century, it's a new normal. Telestroke, telemedicine will become a cornerstone. We mapped out what all can be done using telemedicine at each level, the primary, secondary, tertiary level. And ladies and gentlemen, look at this. Every part of it, in fact, is very little, except for surgery. Almost everything which can be done at a tertiary level can be done at a district level as well. It's just that you don't have CT scan, and you will not have echo and other blood biomarkers which you would require. That primary health center becomes a hub for primarily education and primary prevention, red flagging the big cases, identifying them and shifting them to the district and the tertiary care centers. So the whole implication is to get the right patient to the right place in the right amount of time. And the stroke unit, the concept being that it is, they really turn the chaos into an order, will also be part of the telemedicine. And also screening for the risk of getting a vascular problem, whether it is heart or brain or kidney or what have you. We have development of the stroke risk scorecards, which have been there. You don't have to download the National Stroke Association or that developed by Valerie Fang, which costs money. We have our own development of scorecards, which again can be there as apps on your smart mobiles, getting your test. Now you have Arogya Setu. So same thing, you can have your risk card and you can do it. And the rehab, I don't want to get into it. Nirmal has beautifully brought this down, except that you need also to integrate your own traditional systems of medicine, which are far more sort of more acceptable when you go to the interiors of Indian society. And during the challenges that we are facing in the COVID era, pre-hospitalization, patients with low suspicion of stroke, mild symptoms with no potential indication for acute intervention can be evaluated with telemedicine to aid in determination if they actually have to travel during lockdown, and which we've been doing this. We have, like what Professor Satish Chandra has said, we have now a connect. There is a central station which has been established in AIIMS Delhi, which is connecting to not just public but also to healthcare workers across 100 kilometers and even above. So they can pick up the phone. This is 24/7. So someone can actually call up and say, look, my mother is having this vertigo. And this is a real life scenario, real case scenario, where there was a 65-year-old, a lady who had vertigo for about 48 hours, and they kept saying that it's diabetic and hypertensive and communicated, now do I need to go to a hospital? Now remember, Delhi is also as bad as Maharashtra. We are also at this point of time in red zones, and AIIMS is COVID designate as well as non-COVID, so we have a mix up of these cases. So when this lady had called up, one is that it could still be peripheral vertigo. The other is she's got vascular risk factors. Maybe we are looking at a posterior circulation. So simply taking her through a checklist. Look, do you have a problem in walking? How long does this vertigo last? Do you have other accompanying features? How long has this been? So we've taken through that and decided that she would just need a Vertin round the clock, and then she is improved. And we told her that once the lockdown finishes, then she probably can come down. So this would actually help out wean in those patients who will have to now get themselves transported. Just before we started this webinar, I got a call from one of somebody who's known, and they said that there is this guy. He's living alone. He has a helper. He's got right hemiparesis. Half an hour ago, they can't find an ambulance to travel in Delhi. No ambulance is willing to take them. So I said, AIIMS is open, emergency is open, but you need to come to us. So these are the issues which which are peculiar to this type of the era that we are living in. So pre-hospitalization questionnaire through telemedicine would help. And in the emergency room evaluation, we have heard about protected code stroke. This is a Western thing. Essentially, what it means is an extra layer of protection that both healthcare workers as well as the patients would have, and well-oiled green corridors, which are essentially from the triad system, especially the COVID suspect patients. We are in it. We're doing it every day. We don't have a COVID designate CT scan, but we have a huge checklist which will make it a COVID suspect versus not. We've got developed, we have holding areas, and I guess later on in panel we can discuss about this. And once they are hospitalized, in our COVID designate, which is our trauma center, where we have unfortunately increased number of ventilator patients being admitted, and we are having mortality almost every single day. And now how do you do this? There are 6 people who are on PPEs who are going in there. My own faculty is rostering there. Now they can only be there in PPE for 6 hours, and you can't have too many people going in there. I have a shortage of PPEs, which is absolutely the truth. And then how do you monitor these guys? So we have virtual monitoring. We have in our holding area in Judger, where we're using these smartphones and iPads. They communicate to the healthcare personnel. The patients who can communicate are doing so themselves. Otherwise, the healthcare personnel inside the ICU communicate to the specialists outside so that every time they don't have to go in and out and waste a PPE. Similarly, we're using for diagnostic testing, they consolidated and ordered, and there is a pre-notification which is given. Supposing I'm getting a COVID suspect, I call up the CT scan. So the technicians come down from 3 to 1 and they wear the PPE and they have the exact protocol which is for a COVID suspect. And we have essentially a very high sort of a threshold to order for an MR because sanitizing MR is very tough. And all this is done through a teleconsult. And the telemedicine is also being used on rounds. There are 2 robots which have been obtained now by AIMS, which are also going around themselves. And this you must have seen even abroad. And rehab, I won't get into it. The hub spoke transfers, even now using telemedicine.
Padma, you will have to summarize now, please.
Yeah. So I think, yeah. And so this is the last slide where we've been running the tele OPD services. Now we've almost done about 2,000 patients. The online appointments, and I guess now we're going to start in-person OPDs as well. Again, it's a new normal, defining it. We are defining how to open this in-person OPDs. But the verbal consent taken, recorded, I know I was there when the MCI met and they just passed out this order so that we are legally safe now to be able to give the teleconsults. And the smartphone applications and the virtual consults and the virtual surgery, I think the IT person will be taking up soon. So I won't do the conclusions now. I hope we don't become this during the lockdown era. We're not supposed to be this, right? So this is, and certainly this is not the way we walk the dog. All said and done. So this is my advice to all the youngsters out there. Besides webinars, don't get fixed on to Netflix. Use the time judiciously. And well, everybody dies, corona or no corona, but never ever give up on neurology patients. Thank you. Sorry, I overstepped the time. Sorry about that. Yes, sir.
Yes.
Yeah, Professor Prabhakar, you are the chair. Please invite the next speaker. Thank you, Padma.
Dr. Narasimhan, I think start please, and I will request all the speakers to be on time, otherwise we will not be able to finish it. Dr. Narasimhan, please tell us about the high
mental function. Okay. Yeah, thank you. I'll start sharing my screen. Are you able to see the screen, sir?
Yes.
The screen is visible. Can I go ahead?
Yes, sir. Yes, sir. You can do that.
Go ahead.
Yeah, this is the telecognitive evaluation in the time of COVID. My subject is evaluation of higher mental function. Before that, I thank all the doyens of neurology, Nirmal Surya, Dr. Gagandeep, Pramod Paul, G. Prabhakar, Satish Chandra, sir, all my teachers. I pronounce them from Chennai, and I go ahead with this. How do I do on higher mental function? This was the era where the doctor and the patient were treated by side of side. Now what has happened is that corona has distanced us, and doing a higher mental examination online has a lot of challenges. Let me take you through my views, but this talk focuses only on the adaptation of cognitive tests to suit TeleNeurology. It does not focus on the interpretation and localization of the results. I'm going to tell you exactly how to go about it. I'm not going to talk about because time allotted to me is 10 minutes. So what I have decided is I have just classified all this into from easy to difficult. The first one is a verbal interaction, where you ask questions, the patient answers to you verbally. The second set of tests are where you are showing you visually something and the patient will respond verbally. The third one is a verbal, you are verbal, and the patient has to look at something visually and then do it. And the last one is you are also visual and he is also visual. I will just explain this to you. But what is important is the last one, the visual, is the most difficult one. I have color coded the test so that you will be able to understand what it is. So in a visual verbal interaction, these are tests that requires examiner and the patient to interact verbally and hence minimal technology requirements. Examiner is verbal, patient is verbal. The second set is visual verbal interaction, the test that requires examiner to interact visually and the patient to interact verbally. For example, examiner shares the screen. Examiner shares the screen with a PDF and patient replies verbally. The third set of symptoms is verbal visual interactions, where tests that require the examiner to question verbally and the patient to interact visually. The examiner verbally interacts and the patient writes it on paper. The fourth one
Lakshmi, I'm sorry to interrupt. Your voice is getting break, so please check that.
Oh. Is it okay, sir, now? Is it okay?
Yeah.
The fourth one is visual interaction. And now you look at the screen where what does it look like? The first one looks like a micrographia and the second diagram looks like a visuospatial deficit. But unfortunately, the first one is by writing on a stylus, it looks like a micrographia, but it is not exactly micrographia. And so, in fact, these are all normal subjects. When asked to interact on the screen, this is how it comes. So, we don't have a normative data on when do they interact with the screen. So, not the same as writing or drawing on the paper. If asked to draw on paper, am I audible? Sir, is it okay? Am I audible?
Yes, you're audible.
Yes.
If asked to write, pardon?
Yes, fine. Yeah.
Okay. If asked to write or draw it on paper and show it on the screen, you will see that it laterally flips. Either you have to ask the patient to show on a project it from the beginning with the torch so that it flips, or you have to flip the data, whatever data. So this is one challenge with the which when you interact on a smartphone and ask. The second thing is these are the things which you can observe. You can observe for apathy. You can observe whether he's maniac. You can observe for the pseudobulbar effect, irritability effect, inquire about delusions and hallucinations, and the social cognitions, the different facial expressions you can always look through. And the verbal interactions, the tests that require more visual interactions and technological interactions are proportionately difficult to the severity of dementia. It also, especially longer sessions. Hence, it is of utmost importance to reserve harder tests that will be further contribute to diagnostic evaluation. Verbal interactions, it's very easy. Attention and executive functions. You can do a digit forward, digit backward. You can do a random letter test, serial 7 subtraction, motor luria, verbal similarities, conflicting instructions, go-no-go test. Go-no-go test you can always use instead of, you can use asking to one other thing, you can use the hand clapping and proverb interpretation. All these things can be just done on a verbal. You just call him, you will be able to answer. Similarly, when evaluation of language, spontaneous speech can be evaluated, fluency, sentence length, prosody, paraphasia, neologisms, letter fluency, category fluency, pointing commands, 3-step tasks, repetition, naming, all these things can be done verbal to verbal interactions. Memory, orientation to time, place, person, 4 unrelated words, recognition, registration, recall, questions, recent events, fund of knowledge, the personal information, story recall, new learning and paired associated learning, all these things are pretty easy. We can go ahead with verbal to verbal. And visuospatial, you can always ask him to show where is the window in his house, where is the door in the house. Calculations, practice and noses, addition, subtraction, right-left orientation, finger noses, and all these things can be done just on a video call. Transitive and intransitive commands, ideomotor apraxia, ideational apraxia, deafness levels, coin flipping, finger tapping, all can be done on a smartphone call. And so these are all the tests which are done on a thing. And then coming to the visual verbal, where the language you have to ask him to read a paragraph, assess reading comprehension. So you have to show a paragraph, ask him to read. So you are verbal and he is visual. The second, the visuospatial geography, you show something and ask him to find out in the picture where it is. So again, he is visual. So the gnosis is you can show a color and ask him to name that. The third thing is the verbal visual interactions. And for example, language, ask him writing a sentence and spontaneous and to dictation. Visuospatial, the clock drawing test. Like ask him to draw a clock, give a time and ask him to draw, and then send in the projection. The last one is the tough one, the visual interactions, where the shapes, the graphic luria, the copying written material, the visual memory registration, reproduce visual sequences, the visuospatial neglect. So this part definitely requires a platform where he has to interact with your screen. So how do we design? I just come back to that a little later. So these are the tests where you do both visual interactions, the graphic luria and reproducing shape. So the advantages are assess the patients during difficult times of COVID, continued care of patients, minimize infections with healthcare workers. So study-based evaluation shall be the norm of the near future. New normative data you have to create for the test when significant technological interactions are required. Training of healthcare personnel towards digitalization. A single interface with two interactions between the examiner and the patient is required, and the normative data to be established for the same. You would have understood by this time that 75% of the higher mental function, you can do it by just a smartphone call. And so many interactive apps which can do that. But the most important one which work on the health screen, the bottom four, the Practo, the Find, the 1MG, and the Team Viewer. I looked into each one of them. I found that the Team Viewer has an HIPAA compliant platform where you give a username password to the patient and they log into the screen. It's a platform, one-to-one platform between the doctor and the patient where he can interact on your screen. The only issue is you must use a specific a laptop where you don't store any important data, even though the Team Viewer assures HIPAA compliance and 100% the verified protection rate, and it doesn't have access to any one of your other files. But you can't, the hackers are pretty as good as the programmers. So you must be aware of that, and then choose a platform where you can interact with the patient. That is going to be the future, and Indian Academy of Neurology should also write to the people that we must, as Nirmal has rightly put, how the paying interface is as important as for us. We also have to survive this tough time. Thank you very much for your attention. Thank you. Hello, can you hear me?
Yeah, sir. Professor Satish Chandra, can you take it forward? Thank you.
Save 2 minutes of your time, Dr. Nirmal.
Yeah. Professor Satish Chandra, can you invite the next speaker, please?
So your microphone is muted.
Yeah,
sir.
yeah. I'm audible now?
Yes, sir.
Thank you, Lakshmi Narasimhan, for bringing out the higher mental function examination very quickly within a short period of 10 minutes. But I'm sure people have understood how to go about it. Now we move on to the next level of examination, which is the cranial nerve examination. To talk to us about this is Professor Madhusudanan, who is very well known neurologist and very well versed in neurological examination. Who can have a better teacher than him? Over to Madhusudan, please. Madhusudan?
So we don't.
Madhusudan?
Dr. Madhusudanan here. I mean, he was there, but I think he has been logged out.
He's logged out. Oh. Because he was supposed to speak now on cranial nerve examination.
Sorry, sir, I wasn't able to hear you. You were muted.
Maybe the next speaker,
Dr. Surya.
Sumit is the next speaker, sir?
Can we have the next speaker, because Madhusudan had some issue of the internet. He might be trying to log in from phone. So we can have the next speaker. Sumit is there.
Yes, I can take up.
Yeah, Sumit can take up.
So do I have permission to start?
Yes, Sumit.
Okay. Is my screen visible?
Yes, now it is visible.
All right, so I've been given the task of motor and sensory examination on a TeleNeurology platform. The time which has been allotted to me is 10 minutes. I think it is time enough, because I think we've seen that in AIMS, where Dr. Padma sees about 170 to 200 patients in a single day, where the time when you have a physical evaluation of the patient in front of you is less than 2 minutes. Therefore, 10 minutes is actually a okay time. There are several types of teleneurology: the telephone, email, and a video consultation. And the only video consultation would give us an opportunity of an examination. There would be two broad segments: a home video consultation, which is more common in India, where the patient is not accompanied by a trained medical professional, and a video consultation at a telemedicine facility, where a trained medical professional is available and can elicit the neurological examination, which in turn is observed by a distant neurologist with confidence. In home video consultation, only observation is possible, which has its own limitation, but still lots of meaningful conclusions can still be made. There would be two groups of patients which would seek this evaluation. One would be the follow-up patients who require either a re-prescription, where examination might not be of that relevance, or others who develop new symptoms, worsening of older symptoms, or complications of treatments. And there would be new patients who would require teleconsults for various reasons. Patients is not with the consultee, he's admitted in a hospital and a second opinion is needed. Examination is not possible and is not needed. Patient is referred to you but can't travel, has had no previous neurology consultation. Patient is referred to you by a neurology colleague because he pertains to your special area of interest or research. Patient seeks a novel consult by the Google search, most dangerous group. And patient already seeking an opinion from a neurologist who's seeking a self second opinion. So the second, third, fourth, and fifth group are the patients who would require a evaluation. The problems which are specific to India, that there is a paucity of telemedicine center. Even if they exist, there's a paucity of trained staff. No doctors at the telemedicine center. At the times of COVID-19, none of these centers would be operational. In rural India, there is no internet, no 4G, and maybe no smartphones. And at all times, till date, teleneurology might actually be confined to a home video call on a mobile. But this has to change in the near future. The new normal for a long time will be social distancing and impervious borders. So local travel might be more convenient than a long distance travel. And in present scenario, the patients and their caregivers might be the best possible help to a neurologist. And of course, there would be issues of payment options. So I would say it's a video observation rather than an examination of the nervous system. The things which we need ideally as prerequisites are the ones which are out of the bracket, but what we get is the one which are inside the bracket. So one needs to have privacy and adequate lighting, clear voice, plain background, loose clothing, couch for the patient to lie down, area to walk, visibility of the patient in full. And the most difficult one is an intelligent attendant, and undoubtedly a corroborative history, which is the most important. The objectives of the examination would be for the motor system to see whether the wasting is present, if it is generalized or localized to individual muscles, is there a hypertrophy, whether the tone is increased or decreased, is it pertaining to the extrapyramidal system or its spasticity, is there a weakness present, if it is present, it is symmetrical or asymmetrical, if it is, then whether it is proximal, distal, or mixed, can we elicit some reflexes, are there any cerebellar signs, what is the gait like, is it slow, short steppage, spastic, high stepping, ataxic, or are there any abnormal movements, and if they're present, then what are the types? In the sensory system will be more difficult to perform because it's a no-touch technique. It's a subjective evaluation by a non-medical professional. There is no objective way. The modality of the sensation affected of the small fiber or the large fiber is difficult to elicit. And at best, we can find the distribution of the sensory loss, whether it is pertaining to one nerve, to multiple non-contiguous nerve trunks, or it is a distal symmetrical sensory impairment. What can be done on a motor system examination is a rough prediction of wasting, the presence of what type of tone abnormality, a rough estimation of power. Some of the reflexes can be elicited. Gait can be fairly estimated. Abnormal movements can be very accurately evaluated. But what can't be done is an accurate estimation of spasticity, the reflexes, and planters. Now, this is pertaining to home-based video evaluations and not to a telemedicine facility where a doctor is physically present. We disrobe the patient for doing extrapyramidal evaluation. We do a UPDRS evaluation and observe for abnormal movements. Ask the patient to shrug the shoulders with the attendant pressing down. Ask him to clench the fists around the fingers of the attendant. Get up from a squatting position, walk on toes and walk on heels. Ask the attendants to percuss just below the patella, and we can demonstrate the attendants as to how to do it. Observe while they perform the cerebellar tests like the finger nose, finger to finger, dysdiadochokinesis. Observe for the gait. Look for associated movements, whether there is apraxia, ataxia. What is the position of tandem walking? Look for abnormal movements, the type, character, association with motion, the distribution of sensory abnormalities. The distribution of abnormal movements. Are there any sensitivities or any sensory tricks, and is there a task specificity? So we can look for the wasting, for example, the hypothenar and the thenar eminence, and the wasting of the common flexors in these patients with bibrachial amyotrophy, the winging of the scapula and facioscapulohumeral muscular dystrophy, and the hypertrophy of the calf muscles. We can ask the patient to walk, and we can have a lot of information of these patients while walking, where this patient, you can see, is walking with a hemiplegic gait, with a circumduction of the lower extremity and the flexion of the upper extremity. And this is a teleconsultation of a patient with extrapyramidal abnormalities, Parkinson's disease, where you can very easily see the presence of bradykinesia and a significant amount of slowness, and the extrapyramidal rigidity, which is very easily available. We can very easily perform a unified Parkinson's disease rating scale on most of these patients with the very easily with the video platform available. So you can see this alternating fist clenching and opening, alternating finger tapping, alternating pronation and supination of the wrist, and we can very easily elicit the asymmetry which is seen in these patients. For example, this one who has a better movement of the left side as compared to the right side. Proximal or distal muscle weakness can be elicited by asking the patient to sit down and get up from a squatting position, like this lady who presented with weakness of the left more than right side of the body for last 15 days. So you can see that when I ask her from getting down from a stool, there is a significant amount of difficulty. So proximal muscle weakness is definitely present, and there is some amount of weakness of the dorsiflexors of the foot. And you can see that when she tends to walk on her feet, particularly on the toes, she becomes a little ataxic, and she has this jumpy gait, which probably indicates that there is some amount of increased tone. And when I asked his husband to tap on the knee, then you can see that there is a distinct asymmetry of the reflexes, with the left side being more brisk. So when we did an MRI of this patient, we found that she had demyelinating disease, probable multiple sclerosis. Normal power with impaired tandem gait could be seen in involvement of the cerebellum. For example, this young girl who had no weakness when we asked her to get up from a squatting position, but you can see that for her age, she has a mild impairment in her tandem walking. She had tube-effective demyelination with the right side of the brain affected, with the right cerebellar peduncle affected. Abnormal movements are very, very easily elicitable, and they are very, very easily describable and classifiable on a video consult. Meigs syndrome, paroxysmal kinesiogenic chorioathetosis, lissuride associated extrapyramidal syndrome like Parkinson's disease presentation, essential tremors, cervical dystonia and blepharospasm, and patients with the Gilles de la Torre syndrome. So clinical evaluation of extrapyramidal features is more easy as compared to a clinical evaluation of pyramidal system on video evaluation. Sensory examination is very difficult to perform on video-based consultations without a trained professional on the patient's end. What we can do is to see whether there is a presence of a sensory loss. We can also elicit the distribution of the sensory loss to some extent, but what we can't is, we can't type the type of a sensory loss, which is almost impossible, and also quantify the sensory loss. We can ask the patient to self-assess the sensation depending upon the symptoms, where mononeuropathy would be a distribution of impaired sensation in one particular nerve, for example, in carpal tunnel syndrome, ulnar neuropathy, or a common peroneal neuropathy causing a foot drop, in mononeuritis multiplex, and in peripheral neuropathy. Sometimes we can elicit to some extent a rough level of a sensory impairment if it is present. But sometimes it is very easy and very important that a video consult can help us in actually explaining the diagnosis correctly. For example, this patient with carpal tunnel syndrome, who says that there is a vague pain all over the hand. She says the pain is more on the right side, on the medial aspect or the lateral aspect of the hand as compared to the medial aspect. She does not say that there is a sensory impairment, but when we ask her to touch her thumb and the little finger, she is able to say that the little finger feels a little better. And then when we ask her to evaluate on either side of the ring finger, she's clearly able to say that the ulnar side is relatively spared. So in such cases, if there are intelligent patients, some degree of information can be elicited even on the sensory examination. And of course, we can ask the patient to perform a Romberg's test. And this is quite easily elicitable on a video consult. So at the end of the examination, one has to give a diagnosis. We have to give a prescription. Always, it is important that we have to write on the prescription that it was a video consult of Mr. or Miss or Mrs. So-and-so. This is the possible diagnosis. These are the suggested medications, and it should be clearly imprinted on your prescription that it is not medico-legally valid. So as a conclusion, we can say that teleneurology is an evolving science, keeping its baby steps in India. COVID-19 has definitely created a unique opportunity to assess the potential of this modality. The restrictions and impervious borders are the new normal. Therefore, teleneurology is the new routine. Neurology examination on teleneurology platform is a challenge, and it needs to grow and evolve. We need to have dedicated centers, evolve courses on teleneurology, and train the doctors at the center to perform a meaningful neurological examination to assist a distant neurologist to extract maximum information. We need to have authorities to modify the existing laws to promote and felicitate telemedicine and keep the medical legal framework out of the perjury, at least in the time of present crisis. But over better timings, it would be required to perform audits so that more standardized formats of teleneurological examination can be established. And one has to encourage online payment options, which are undoubtedly an important part, more for the private sector than the government one. Thank you very much for your kind attention.
Thank you.
Professor Prabhakar, invite Madhusudan. Is Madhusudan back? Bhavesh, can you check? Mansi, can you check Madhusudan? I can't see.
Yes, so he was there. Now again, he is not there.
Yeah, I think he's having problems. He got back, but now again he seems to be missing. He was here.
I think what we can do, we can go to the next talk and then we'll see how we can connect with Dr. Madhu. So I'll call Mr. Pankaj Sindhu, who is going to talk about digital platform for neurologists for future. Is it okay?
Yes, sir.
Okay, fine.
Thank you, sir. Thank you, everyone. Can you see my screen and hear me?
Yes.
Okay. First of all, I'll start by saying phenomenal people. Grand salute to doctors who are all out there helping people like us out there. Just a quick introduction about myself. I have been into health technology for a while and worked as CTO in few pharma companies. Now, just to start my talk, I would say that I'll have the opportunity, at least when I grow old, to tell and read a book to my child and say that once upon a time there was an era which was called COVID. That's the kind of impact it has brought onto us. And just to start, it took COVID to happen, really let everyone think to firm up guidelines on telemedicine. And thanks to the government for bringing out the telemedicine guidelines. Now from the guidelines, I'll not get into much of it, but just a few points from a technology perspective. So for telemedicine, any channel, whether it's voice, video, text, or any kind of digital exchange falls into that. What is excluded of telemedicine right now is surgical or invasive procedure and any consultations outside India. That's also, I believe, is not allowed. Any critical emergencies also are not part of it. So even if we have complex systems which can do that, I guess that's not allowed as of now. And wherever there is a consult, there's a physical examination, I guess that's where consult in person is also there. And while looking at presentations from Dr. Lakshmi and Dr. Sumit, I guess there can be still systems which can be really doing a lot of those assessment, but I guess the framework is still not yet ready on that. And finally, before any teleconsultation ends, it's mandatory to submit the handwritten or whatever prescription to the patient by that digital medium. Now, just a quick fallback on the telemedicine part of it. In 2001, I think that's where the first telemedicine concept came in place with, I can say, a more complex one, wherein Dr. Jakes from New York was doing a gallbladder removal surgery of a 68-year-old woman who was sitting out in France. And this was a total robo-assisted ATM methodology with very limited response time gaps in between. Now, the grand thing of this was that definitely even the invasive things can be done through telemedicine. As country, we are yet to move on there. But the second complex thing was that it costed around 11 million, not because of the technology, but because of the frameworks which were missing, and US was not willing to take up those kind of risk on its soil. So both the technology and the guidelines have to go definitely sync in hand on this. While we have spoken about it, I'll stress upon a few points over here from a telemedicine perspective that definitely it helps a lot of pandemics, epidemics like this. This is the solution when people are not able to move around. Another very important point, Dr. Prabhakar and Dr. Nirmal also said that accessibility to the rural guys. Telemedicine is one impactful, I would say, arena whereby people from all over the country can get access to this. There can be mechanisms set up definitely. And two more points, especially maybe related to neurology, would be because even if we develop a very complex and very easy to use system, there is a lot of data in terms of video, photographs, movements, all that is being taken up and captured. You will need system which is able to give you data retrievability with ease. A system wherein you can get the data visibility out there on that. So in neurology, definitely the telemedicine has to be I would say, expanded beyond just the tele and the video consultations. There have to be more device-assisted technologies which can be weaved into the system on that. Now let's look at quick process flow from a simple stuff. While Dr. Lakshmi pointed out some systems out there, but I'll just give you what could be a good mechanism and what should you choose, because eventually you have to look at on a day-to-day, maybe manning 100 patients, 30 patients, 90 patients, don't know. So it should be as easy for you to just set up your own profile and have certain features which are out there whereby you can define your first time consultation and even repeat. Most of the telemedicine gateways don't have a repeat consultation mechanism right now. So this is something which is very important for you as a doctor, because the pricing should be transparently available to the patients, and it should be an advance payment. So when a patient wants to consult, there should be a payment mechanism. It should be done, and then it comes back to you. If in case you are not able to confirm that appointment, the money can be always refunded back to the patient. So this gives in a lot of credibility that patients who are serious about consultation are only coming up, and it's just not that I want to block the calendar of the doctor and last minute I am not visible. The another good feature, and I'm trying to show you various feasibilities and simplicity. Let's look at this volume. There is a lot of biography which you would want to speak or talk about. Now, people who would want to listen to your biography instead of just written, would they have an option? So I would say that these kind of recording your biography, which can be eventually listened by the patient at his hand, should be a unique feature which could be available to you. It's easy but unique. From a patient end, it's very easy. They just send in request, and once this particular request is there from the patient, he will say what exactly he's choosing, whether text or whether tele, video, depending on what you have approved, and a priority call. In case the patient wants a priority call, there is a different charge, let's say, for that. And he goes through his various problems, and he can describe his problem by typing or again by recording. So we can give a 5-minute recording of problem to the patient, whereby nicely he can just explain what he's going through, especially for new patients and even for other patients. And in case that patient wants to send some prior prescriptions or reports, they should be allowed to attach that. Eventually, when a patient comes to you on teleconsultation, the more informed data you have, the better prognosis would be possible at your end. And then in one single step, the patient should be able to book the appointment. And once he books the appointment, how does the whole process flow begins? So we have just covered setting up a profile in one single step with easy things like bringing up your audio stuff on that by recording your biography. Same is with the patients. He can record his problems. He can attach a lot of his papers over there. And when it comes to you, it comes in queue. Now over here, you can just simply click on confirm, see whether your calendar is available. And if you're doing even post-COVID, let's say if you're doing your normal clinics, you can always maybe set up a time between your entire day wherein you would want to take up some kind of e-consultations as well. So you can always check your calendar and confirm that. The moment you confirm it goes into your confirmed section, and that's where only those things will be in queue which have been already paid for. So as a doctor, you should not receive any, or you should not be bombarded, I would say, with the consultation requests, which are just requests, but without any payments to be taken up. And in case your calendars are busy, you can always do a regret, and there are chances that you will also miss the consultation. So there is a mechanism, how smooth and how easy it is for the patients to know that it has been missed out. And then while you are on the call, now this is also very critical, that one is that you should be able to add more people. Let's say if one doctor wants to invite another doctor, there should be an ongoing call feature which should connect the second doctor, or even for a patient, if he wants to get his caregiver involved, it should be there. Now, not only that, from a doctor's perspective, I feel your time is very critical. So if let's say you say that you have set up maybe 10 minutes as the maximum consultation time for e-consults, if it is coming to near that particular thing, you should get some kind of this message. If you can see, e-consult time limit is about to get over in next 2 minutes. So this is the kind of reminder to just keep you on check on the timelines. And then you can do some add-on chats, which could be available for another 2 hours, but then it gets closed. Because opening the chat consistently and permanently for patients might again be taking up a lot of your time. And finally, you have a call closing whereby you write a prescription, handwrite it, attach it to this whole thing. And even you can record certain instructions. Now, and this comes handy not only in your clinics, but while you are doing a face-to-face consultation. I would say for a remote patient, how he understands and interprets your instructions is very, very important. So a positive treatment outcome for a patient would mean that he adheres to your instructions very, very carefully. And you can always record these things over here, and it gets relayed to the patients through your recording. And then you can just simply submit. So this is a very simple flow, what's there. Now, if we look at the perspectives from the doctors and patients, and while there are ease of use, this is how you would choose whether the system is really easy to use. You would not want complex hundreds of solutions and efficiency features over there, but you would want to see how easy it is for me. What is the platform's efficiency? Even like video platforms, there are different efficiencies in video platform. How well is the compression technology? How well is the video able to transmit a nice clear video even over a lower bandwidth? Those are the complex features which you would want to look at. Now, if you look at both sides, most of the things would remain same except the payment part. There might be some misunderstanding over here. So from doctor's perspective, I would say it should be an advance payment. But if I look at the patient's perspective, they would want payment refund guarantees in case it was a regret or missed consultations post the payment. So there has to be a process to really efficiently do that. Now, what are the platforms available? Let's quickly look at that. So one of the platforms is wherein you have today smart RX papers and a digital pen, which can eventually be upgraded into a full-blown e-consultation solution. Very easy to use. You don't have to learn any kind of software for that. No behavior change. Very high productivity because you don't have to still type back anything on that. And it can be integrated with your consultations, payment gateways, and all. And the impact from a patient side, if you look at, you are able to maintain an eye contact with the patients in clinic or beyond as well. And if you look at the pricing, their pricing would range between 18,000 as a one-time to 30,000 rupees. And the ongoing cost is going to be the paper part of it, and definitely the platform subscription. The second mode mechanism would be wherein you have got a laptop and a desktop at home with a printer, wherein you would want to do e-consultations, little bit of change of behavior, because the love of writing is there in every doctor's blood. You would not want to lose that. Definitely, here RX writing remains separate because you have to click pictures and then upload it over there. Your eye contact normally gets lost because you are more bothered even on other stuff, what's going on in the screen in terms of your prescription and captioning and other stuff. And you have got a limited patient engagement over here. Cost-wise, I would say if you add up the laptop desktop cost, will range somewhere around 30 to 50,000 rupees. And then ongoing, you would have a lot of printing costs, a lot of hardware maintenance costs, both the laptop desktop or the printer, and the subscription definitely. And last would be your, through a tab or a mobile attached to a printer. It's very, again, look at the, convenience part of it. You have to select from drop downs menu. Could be time consuming at times, could not be possible that certain drugs are not available, might take on those, you might get stuck at that point of time. On the feasibility part of it, you will still have to have ERX integration. Apart from it, has got integrated payment gateways all across. And from a price point, again, this will be somewhere around 20 to 30,000, depending on what mobile, what iPad you're choosing. So these are the different parts of it. Quickly, with the leaving thoughts on my last slide, telemedicine is here to stay because the kind of environment we have seen, it's coming up extensively, and you know your workflow best. So nobody, no player, no provider can define your workflow. So the system should have the capacity to accommodate to your workflow rather than you are accommodating to the system's workflow. It will be a good idea to understand who designed the platform, because there are a lot of techies who would be out there, but do they understand the domain? Do they understand the pain points? Is something what you should look at. Is the technology in the cloud? I would say cloud is more safe, secure in terms of your data continuity, data retrievability, size of and the scale of data, what you can always have. And overall, the ease of the technology, what you are looking at, apart from the security as well. The security might play a over increasing role as you move into it. where the system is hosted, how secure is that, what are the kind of internal policies the company has, what is the kind of encryption on the data, is any identifiable data encrypted or not encrypted. So those are the few questions which you would want to ask any vendor on it. Now, last very important point, which I want to leave over here as a leaving thought is, while teleconsultation can give you a very normal basic flow to work, but every specialty, and let's say especially neurology, would have a lot of extra additional things to be done, like your motor movement, the sensory, and a lot of other things to be captured. Now, if you want to get an innovation from that kind of an e-consult platform, and these are all doable. You have got fantastic microbots, robot-assisted stuff. A lot of your trouble, what I just saw in both the presentations from Dr. Lakshmi and Dr. Sumit, can be achieved over here through assisted devices which are attached to your e-consultation platform. But for that, what happens in the industry is that out of the 5,000 neurologists, there might be maybe 500 different players who are there. Now, these 500 different players would sell and do and are done with the entire sale of it, but they are not able to innovate the platform. Now, imagine if the Neurology Society was able to filter through one of the best or few of the best guys who understand this entire space and give them the mandate to develop a system which fits the neurology, not just the e-consultation, but with the assisted device. We can always invent something new. We can always discover what can work over here. So imagine those kind of continuous business to those kind of vendors, those kind of inputs to those kind of vendors would give you a world-class platform, which not only we will be using in India, but definitely it can be taken out globally, where I can assure you nothing is there of that kind of a sort. So thanks a lot once again for your time, and appreciate. Thank you.
Dr. Madhusudan is there. So
yeah, come back.
Madhusudan, I think you have come back now.
Yes.
Am I audible?
Yes, sir.
Madhusudan is very well-known neurologist and is very good in neurological examination. May I invite Dr. Madhusudan to talk about the cranial nerve examination in the next 10 minutes. Madhusudan.
Okay. Thank you very much, sir. First of all, let me express my apology for moving away in between, because I got a tremendous problem with the net connection. So without losing time, so I will share my platform now. Just 1 minute. Can you see my slides?
Not yet. Not yet.
Not yet. Okay, then I think the other person has to switch off his.
Sir, I have done that already. I have stopped the screen share.
Okay, then I will do once again. Can you see now?
The screen, yes.
Yes.
Okay.
Go ahead.
Okay. Just like Lakshmi said, as far as cranial nerve examination is concerned, it's largely a symptom-oriented approach. It's usually verbal, and the visual verbal is important in many situations, but hardly is possible as far as cranial nerve is concerned. So in my talk in next 10 to 10 minutes, what I am planning is to give how to approach symptom-wise to arrive at diagnosis. So the most important thing is to get a good history, as you all know. I go one cranial nerve after another, which is feasible. As far as second cranial nerve is concerned, the complaint of the patient is visual loss. Now, when the patient come to you with a complaint of visual problem, first of all, you have to find out is a real visual problem or not. It's a problem of lesion in the visual pathway or not. Because many other conditions like diplopia, etc., the patient may come to you with a complaint of visual problem. So the one simple question you can ask differentiate whether the problem of visual loss is to diplopia or not is ask whether the visual problem improves by closing either eye. If that is so, that means it's not a problem in the visual path. If it is a real visual loss, then again the problem comes to differentiate whether it's an acute onset or a chronic one. Many people, it's important to differentiate whether it's a sudden onset or a sudden discovery. If the patient inadvertently cover one eye and then notice a visual problem with the uncovered eye, that means we do not know the exact duration. If the patient notice something wrong with the vision with both eyes open one day and then realize after closing either eye that one eye is blind, that means the visual problem is acute and onset. It is something difficult to differentiate history-wise whether the problem is unilateral or bilateral. You can mistake unilateral for bilateral disease. The patient may say that visual loss is affecting one eye, where in fact the affection is bilateral. As you all know, hardly ever a patient homonymous myopia come to you with a complaint that I'm not seeing on one side, one half. They say only one eye is blind. Similarly, you can mistake bilateral for unilateral disease. Patient may say his visual loss is affecting both eyes acutely, where in fact the new affection is only unilateral. The patient must have had lost his vision for long back, but he must not have noticed it. When the other eye got affected, it became compressed notice and it's complained to be acute bilateral loss. So always ask whether he covered each eye to specifically to check whether the loss is unocular binocular. Then the other thing which you can do is to differentiate acute loss, differentiate whether the unilateral loss of vision is due to retinal problem or optic nerve problem history-wise. 3 points can help to differentiate history-wise. Monocular visual distortions like alteration of shape and metaporopsia are highly characteristic of retinal disease. If pain is associated with visual loss, it says more of an optic nerve disease rather than retinal disease. And positive scotoma, seeing black in front of the eye, is suggestive of retinal disease. Now, testing visual field is very difficult, but one way you can do is ask the patient, look at your own nose and then ask him whether which part of your body he is able to see or which part of the surrounding he is able to see or not see. This you can extrapolate to check the visual hemianopia also. This is another simple method. We've got a bystander with the patient, ask him to show a string like that, and then point to the middle part of the string to check the visual field. Coming to the extraocular cranial involvement, the combined will be diplopia. Just by analyzing the diplopia, we can largely come to a conclusion which cranial is at fault. Here you have to ask 4 questions: whether it is uniocular or binocular diplopia. If binocular, the separation is horizontal or vertical. In which direction is the maximum separation? Is immaculate or not? If it is uniocular, your problem is settled, the problem goes to the ophthalmologist. If it is binocular, find out whether the separation is horizontal or vertical. Horizontal means, as you all know, it's either lateral middle rectus palsy. Vertical means it is a vertical movers are affected. The next question is whether diplopia is only present or worse in one particular direction of gaze with near or distant visual task. For example, if it is a horizontal separation of images, the middle rectus weakness causes diplopia that is worse for near vision than for distant vision, and worse on the contralateral side. Lateral rectus weakness causes diplopia when the patient looks at far out. So by these 2 questions, you can differentiate whether horizontal diplopia is due to middle rectus or lateral rectus. On the other hand, if it's a vertical separation image is the problem, then again find out in which direction is maximum. If diplopia is maximum when the patient tries to go down and to the left, the culprit muscle is likely to be one of the yoke muscles acting in that direction, that is right superior oblique or left inferior rectus. On the other hand, if the vertical separation is maximum looking up and to the left, the culprit muscle could be either left superior rectus or right inferior. It will be difficult to differentiate between these 2 things, but it's possible. Which yoke muscle is weak out of the 2? As in that example of a vertical diplopia which is given. For example, if with the maximum diplopia is looking down and to the left, it will be right superior oblique or inferior rectus. If you examination, just looking at the patient's face, if you find the right eye is up, that means the affected eye is on the right side, right superior oblique. If on the other hand, the left eye is up, the affected muscle is the right inferior rectus. So by this simple examination, without doing a sophisticated thing, a history alone, you may be able to try to find out which muscle is at fault. Then another simple question you can ask is find out one image is tilted or not. Tilting invariably suggests the lesion is in the oblique, and more often, if the pulse is acquired, in the case of superior oblique pulse, it's most often the superior oblique pulse. There is yet another simple method to diagnose superior oblique palsy which I use in my bedside. The patient is asked to look at a straight line on a paper in front of him, placed below and to the right and the left. If diplopia is present, he should be asked to draw the false image. The false image forms a line below and tilted with an arrow pointing to the side of palsy. For example, the patient is asked to draw the line, how he is seeing the line. If he is drawing just like on the right side, if the arrow is pointing to the right side, it means right superior oblique pulse. If the arrow is pointing to the left side as seen here, it's left superior oblique pulse. This is a very simple thing which you, without sometimes even on examination, you may find difficult to locate, find out superior oblique pulse. This is a simple method which the patient himself can do in the piece of paper in front of you. If the patient is cooperate, you may be able to examine the extraocular movements by asking the patient to look in the 6 cardinal positions as you at the bedside. But it will be difficult. It requires, as Lakshmi said, visual interaction. Always do reductions and versions of extraocular movements, because you don't do versions alone. You have to close one eye and check individual movements, that's reductions, to differentiate that the apparent weakness is not due to a concomitant squint, but autoparalytic squint. So you have to invariably do both reductions and versions. Now, another important thing to find out the kind of involvement is head posture. If the patient is tilted to the right side, that means it's right lateral weakness. The patient's head is tilted to the contralateral side and down, it's the superior weakness on the opposite side. So the rule is simple. The head turns or tilts in the direction of action of the paralyzed muscle. So find out the direction in which the head is moving. That's the direction. If that's the direction of muscle action, that muscle is paralyzed. Come to the ptosis. Find out whether the ptosis, first thing is correctable or not. Ask him to close and open. If it is correctable, there are only 2 possibilities: corners, elevated exits. Differentiate between the two. You can ask the patient to look down. The eyelid will be lower plane compared to the fellow eyelid in elevated exits. So if the ptosis is not correctable, think of weakness of levator fibril superioris. Differentiate levator dehiscence from other causes. Compare the lid position in up gaze, primary position, and down gaze. In aponeurotic dehiscence, ptotic lid is lower than the normal lid, not only in the primary position, but also in the down gaze. But in myopathic and neuropathic ptosis, lid position is normal in down gaze. As you can see here, this patient has got elevated dehiscence on the right side. Look at the left eyelid, it is lower even on looking down. That means it is not problem of elevated weakness, it's a dehiscence. On the other hand, in the case of third nerve palsy, which you can see here, there is obvious ptosis looking up and primary position, or looking down, that eyelid position is equal to that of the other side. This can differentiate whether the problem is a elevated dehiscence or third nerve palsy. Of course, you can ask about fatigue episodicity. Then I think we shall skip this thing. The other problem is sometimes patient blepharospasm may come to you with a complaint of ptosis, but it's actually a blepharospasm. The simple bedside thing which you can do is look at the position of the eyebrow and look at the position of the elevation of the lower eyelid. If the eyebrow is down, it is a blepharospasm, because in ptosis patient may correct the may elevate the eyebrow to the frontalis overaction. This is what you find in the first person. This is what you find in persons with real ptosis. Now coming to the fifth cranial now, difficult to test sensation, as Sumit has already told, sensation exam will be difficult. You can ask for the area of numbness. I think I will skip that. The motor part you can test, ask the patient to put pressure with his thumb underneath the chin and ask him to open the jaw against resistance and look for the deviation of the jaw. And here one caveat you must be aware, in temporomandibular joint disease, the jaw may get deviated to one side with the jaw opening, especially towards the beginning of the movement. But however, it may ultimately come to the midline towards the end of the jaw opening. So that can differentiate whether it's a true weakness of the motor, weakness of the lateral pterygoid, or an apparent temporomandibular joint disease. Come to the seventh nerve, facial asymmetry is quite common, especially in the elderly. Don't go by that alone. So seventh nerve is one muscle which can be tested by teleneurology. Apart from looking for the facial elevation, you can look for the frontalis, orbicularis, convex, etc. And one useful point to detect orbicularis weakness is looking for the burying of the eyelashes to detect subtle orbicularis weakness. And looking for the blinking is a good point, because I should normally blink at exactly the same time on both sides, and the eye normally should be completely covered with each blink. The patient blinks less often on one side or does not cover the entire eye with each blink, it's got a partial element seventeenth palsy. Because human seventeenth palsy, even if it affects our orbicularis, will not affect the blinking. So blinking affection will clearly tell you the patient is having some element problem, maybe CPN with tumor, something like that. Okay, then another thing to remember is that the face is asymmetrical, the tongue may falsely appear to deviate. If in doubt, note the position of the chin with respect to the tongue. A hearing test, you can't use the formal hearing test. One thing which you can do at this thing is that ask the patient rub his fingers together about 30 inches from the open ear. If the hearing is decreased either side, further testing is required. This is a rough bedside technique which patient can do. Come to the vestibular nerve. Always the problem of vertigo comes. Patient may give the complaint of vertigo for many other symptoms like heaviness, feeling imbalance. The first question is differentiate with a true vertigo or a non-specific symptom like dizziness. There are many other vertigo-like symptomatology. I will not go into that in this time. So once we know that it's a true vertigo, we just like vomiting, other symptomatology, and the rotational feeling, etc. The next step is to find out whether it's a benign peripheral cause and central cause. There is an arduous task with the history alone, but these are some points which can help. In peripheral vertigo, there is often a severe vomiting, severe vertigo with vomiting. It's a moderate intensity in the acute central. If tinnitus is associated, is more often seen with peripheral. Imbalance is mild, if at all, in the case of peripheral. Central is severe imbalance. If it is triggered by positional change, it is more often peripheral than central. And if vertigo continues to persist for more than 72 hours, it is unlikely to be a peripheral because it gets compensated whether or not the basic illness is covered or not. Real problem comes when the video telemetry is the patient, Dr. The person previous speaker was talking about the problem of vertigo. When a patient presents with acute vertigo, it's very crucial to differentiate whether it's acute benign condition, vestibular neuronitis, or from involving stroke. This is not applicable in teleneurology. So two things which you can ask, it is a balance. In general, patients unilateral peripheral vestibular loss can maintain balance even when vertigo is very severe. If somebody is 40 with 2% support into the room complaining only vertigo, it's not a peripheral vertigo. Now, the other thing is you could ask for hearing loss. So traditional teaching is that the coincidental hearing loss and dizziness is always peripheral. But often what we find is that in so-called viral labyrinthitis is very rare. In acute vestibular neuronitis, hardly ever hearing loss occurs. In most of the time, it's only pure vertigo. But combined audiovestibular loss is often a sign of a stroke because in ICA infarct, the commonest cause of brain cause of stroke, vertigo, hearing is often also affected because the blood supply to the group is also from ICA. Hence, combined audiovestibular loss should be treated with extreme caution in the emergency department. So two things you can ask for this symptom is really unsteady, social deafness, be careful, we may be dealing with a central lesion like an brain stroke. Come to the 10th nerve, it's again you have to look at the palate and look for the movement and all. Suppose the patient comes with hypophonia. To differentiate hypophonia due to historical weakness, look for the ability to cough. Because in the case of if the patient is able to cough, that means it can be either functional or a spasmodic dysphonia. It's unlikely to be due to an abductive paralysis, adductive paralysis. From the 11th now, you can look for the drooping of the eyelid. 12th now, again, you can easily differentiate by asking the patient to put out the tongue. You can differentiate between LM and UM and tongue. In LM and tongue, the tongue deviates to the paralyzed side and protrusion. However, the tongue deviates the normal side inside the mouth. In the case of UM and 12th nerve palsy, the tongue deviates the paralyzed side just like the LM one, but there is no deviation of the tongue inside the mouth. For example, this lady has got a left 12th nerve palsy. Inside the mouth, you see the tongue is deviated to the right side. But on tongue protrusion, it deviates to the left side. So I think with this I will stop here in the interest of time. So I conclude by telling that it's not a complete foolproof examination, as you will know. It's not possible with teleneurology. So what we can achieve some localization or arrive at a diagnosis by symptom-based approach. Thank you for your patience.
Thank you, sir. Before we take question answer and go to the panelists, I request President Dr. Pramod Paul to say if he has some announcement. Is there? Yeah. Pramod, can you announce what you want to say?
Nirmal, thank you. And it was really a very fruitful discussion.
Little loud, please.
Can you hear me now?
Yeah.
Thank you, Nirmal. And it was really a very fruitful discussion, and it definitely shows the way forward. And just to, before the announcement, I just want to tell that probably we need to take this issue to the MBBS curricula as well as an internship, so that we can have, in addition to clinical examination, tele-examination and certification. This will definitely help. Regarding the two announcement, we have got a proposal to start a tele-neuro subsection of Indian Academy of Neurology, and the proposal has been given by Dr. Viraj, and we are examining this proposal, and definitely it is very appropriate, and we will go according to the procedures laid down by the IN to DC and GB, and probably we may hasten it depending on the circumstances. The other proposal which was just now sent to me by Gagandeep is about a tele-neuro facility whether IN can provide to the patients or to the general population. And that is also very interesting, and probably if we first do the tele-neuro subsection, they can take it forward for a tele-neuro facility. And again, it has to be approved by the appropriate authorities of the Indian Academy of Neurology. Okay. That's all.
Thank you, sir. Before we take to the question answer, there are 15 questions already there. May I ask Dr. P.K. Shetty about his experience on tele-rehab, and what does he think about legal option? How we are going to face the legality while we are doing the consultation with the tele? Of course, this question is going to come again from the question answer session.
Nirmal Surya, I hope you can hear me.
Yes, please.
It's very kind of you to ask me. Actually, I'm very grateful to our secretary and Indian Academy, because I requested teleconference to be put in the schedule of Indian Academy of Neurology. I did not know it will happen so soon. It all became because of COVID and sudden lockdown. Luckily for me, I did not have when it stopped, I didn't have the expertise of Pankaj. I had spoken, I put on WhatsApp neurology, I spoke in daily neurological session that this may be forward so that we can communicate with our large amount of patients which are unattended, unmet needs, with very few neurologists. This I presented in daily neurological session to Pankaj. Was very nice to say that, but I look back when sudden lockdown occurred. I said I will go to WhatsApp neurology. I just want to remind you, Regulatory Association of India, last 2018, there were about 700 million people who have got smart mobile phone, and 400 million people are on WhatsApp. So already we have, this thing has been put into action, and it's a very end-to-end inscription. You can't really, our hospital tried to go into kind of telemedicine, but they found that when the UDID was given, some people got their ID stolen, and they found a lot of money missing and their private data. So WhatsApp is already ready. So therefore I thought I will go to WhatsApp neurology and try to attend to my patient. Dr. Prabhakar at Port had a very nice thing. Initially, when the lockdown occurred suddenly out of blue, 23rd of March, I was not prepared for anything. Few patients who called, I was giving the call on the mobile telephone itself, telling them that to continue the medicine which they were taking. On 7th of April, I really started doing WhatsApp neurology. And now, really, I have seen 107 patients, 107 patients over a period of 23 days, plus 13 calls on telephone, which I gave to them. I have found that this is a good media, and this is the kind of thing which we have tried to write up as a WhatsApp neurology, and we have made a website also by that name. The problem which I am facing, that many times it's difficult, as has been pointed out by Dr. Sumit, when it comes to take reflexes and then comes to sensitive. I had a patient of peripheral neuropathy, which I thought were peripheral neuropathy. The question was this young lady at 39 years old started having weakness of the leg, and which kind of progressed. And at the same time, there's question, like previously 3 months ago, she had some neck pain with radiculopathy.
You have to be very brief now. We are already late. So, and we have.
I take a few minutes. Whether I was having myelitis or whether I was having neuropathy. Then the main thing occurred when I asked her to go to investigation. They are so scared to go to the hospital. The standalone MRIs and standalone investigation are all closed. So this has been mainly given to be on watching and observing, as is pointed out by your various speakers. So you have to give a treatment on this. I think I recommend till you get a new kind of thing, that WhatsApp neurology is very good motive way to go to manage this patient. Each patient is known to be able to download. It is already downloaded with them. They are very quite smart on it. They are in fact better than me. Question comes about the payment. At the moment, I have told them that they can pay me in my account or they can pay by ATM. I'm surprised that I have collection of at least 90% people paid. It is only 10% who said very politely that pay you when the background is.
Thank you, sir. Thank you, sir. I will take the next question to Dheeraj and Biplab. They have developed the mobile app, and congratulations, Dheeraj, for your new initiation. So would you tell me in few words about how this app is going to be useful for telestroke, and how Biplab and you have worked it out together? So one minute, both of you, please. Dheeraj, unmute your mic.
Sorry. Thank you, Dr. Surya. And first of all, excellent talks by all the speakers. Just a short run on my opinion on how things are going to likely run before I talk of the telestroke. One thing is for sure that all the subspecialties of neurology would need to be retrained. Like one person would not be able to likely take up all the neurological problems on tele. It needs a retraining. That's quite obvious. Sumit showed it. Some things would be easy to demonstrate, like ataxias or tremors or some movement disorders. Movement disorder is actually the most visual out of them. And they actually may be most easy. I won't call it easy, but relatively more easy to see on tele-neurology. Things like reflexes, we need to have some more technology, as Mr. Sindhu also noted, and some innovation is needed in that. So as far as the telestroke is concerned, so like for example, my scope was on telestroke, so I just thought of stroke. So the creation of that platform, which me and Biplab have been working on. So I created one which is going to be useful in having team communications, team communication for strokes. So a stroke team which is working within the hospital and which is working in a spoke. So it connects a hub and spoke. The teams can communicate with the basic aim of having least physical contact and pre-notification. So that works on that principle. Team communication, pre-notification, least contact, and EHR. So one thing when one usually questions, even when we talk to policymakers or the administrators, when we needed funding, say, why don't we go ahead and start using WhatsApp, which everyone has been using till now? Biggest disadvantage is it's very distractive. Let me tell you, you're on WhatsApp, you have 10 other messages coming. You can't be focused on that. Number two, you have no records of the patients. You cannot maintain health records. WhatsApp, which is legally a very sore point. And right now, although the telemedicine's guidelines, they allow us to use WhatsApp, but in the long run, that you cannot reorganize your health records, whatever data you have. So that can be done through these platforms. And Biplab has also done a very wonderful job with the Stroke Telecare, which gives you a map, I believe, and Biplab can detail it better. It gives you a map of all the stroke centers so people can reach out, and also has a teleconsult platform on an outpatient basis, I believe. And another thing which I am aware of is the government initiative which has just started, and I've been just told that our tele OPDs, which PJ is about to start because lockdown finishes tomorrow, physical OPDs are not going to happen. So there's something called e-Sanjeevani, which I'm sure Dr. Satish Chandra would be aware too, which was already in use, but now they are innovating for use on personal mobile. So that e-Sanjeevani is likely going to land up in most government setups.
Thank you, Dheeraj. And Biplab, can you add on to that? And can you tell us that how you collaborate MRI with your tele stroke thing, or can the MRI be linked with the digital prescription?
Okay. Hello, everyone. So it is really wonderful to be part of this programs, actually. So just in short, regarding tele-stroke, what we have done already, rather than concentrating on that one, so what are the challenges we will be facing down the line? Because as far as tele-stroke is concerned, although it's a old concept, but in current scenario, we have to make the policy, how to go ahead, and the legal prospect we need to address. We need to have the guidelines and other things. So. And as far as stroke is concerned, other stream is different. Like as Dr. Prana is also saying the same thing, like motor examination and other things. So we need to develop the all modules to develop that one. So regarding the our mobile application, that is Stroke Telecare actually, and that applications you can download from your mobile also, which is free to download from Google's both in iPhone and Android as well. So in that, using that application, this is applications which is made both for public as well as for the hospitals or a doctor. In the sense, the public can download using that application, they can have a basic knowledge about stroke. And supposedly somebody of his or her nearby is having a stroke, and they can find a nearby stroke ready centers anywhere across the border. So that's how we are trying to make a stroke ready center network. I mean, it's a network so that the patients reach hospitals in due time, so that the patients can be treated properly, and from there, if required, patient can be referred to a centers where proper treatment can be offered. And that's how. So using that applications, the hospital can easily upload their images. They can take a consultations to the. They can talk to stroke experts. And the most important, the primary treatment which is to be given, like thrombolysis in eligible patients, can be given at a very peripheral centers, and that's the motto behind this developing this application. Actually,
thank you, Biplab.
Thanks.
So we have our last panelist, Dr. Ghosh. Can I ask you? There are many senior people who are not digital friendly. So, what are the myths you think are among the neurologists about using the teleconsultation?
Thank you, sir. It's a pleasure joining this wonderful panel. So many of my former teachers are here as well. Thank you for inviting me on this panel. Well, there are certain myths that exist not just amongst patients, but also more importantly amongst physicians. And even though there are obvious advantages with regard to the COVID-19 pandemic, where people have to travel and they can stay at home and avail of these facilities, and also post-COVID-19, the advantages would include saving time and preventing loss of time from work. But some of the myths that plague us is that an appropriate neurological examination cannot be carried out. While I am an advocate of telemedicine, I also believe that it is imperative to have a first visit, perhaps, not in the COVID-19 times, but post-COVID-19 at least. First visit at the clinic or the hospital where a thorough examination is carried out. And then subsequently, if further visits are carried out by telemedicine, perhaps improves diagnostic accuracy. The other myth that is faced is that most people beyond the age of 65 or 70 happen to be technologically handicapped, and there's a generation gap. This generation gap concept is perhaps becoming outdated slowly but surely. As in today, more than 40% of people above 65 are using smartphones and Android phones and so on and so forth. So they have access to digital media and they can communicate. The other important aspect is that sometimes people believe that there is a lack of empathy and perhaps a lack of satisfaction in teleconsults. There's an important paper for a study done in Cleveland Clinic, which suggests that almost 90% of patients who've been visiting telemedicine facilities or carrying out telemedicine visits from their home have not suggested a decrease in their satisfaction levels. They have either been more satisfied than visiting their patient clinics, and for others, they have maintained status quo. So I also believe that as physicians, we could be a little more empathetic towards our patients during these telemedicine consults. And one of those would be, rather than asking them about their problems first up, would be to greet them and perhaps allay their fears and make them more relaxed while engaging in these telemedicine consultations to kind of break the barriers.
Thank you, Dr. Ghosh. Before I hand over to both the chairperson for a couple of important questions which has put in, I want to request all the speaker, could they make a standard disclaimer for the teleconsultation, so that everybody who does teleconsultation can have been given to the patient beforehand. Thank you.
Hello.
Professor Prabhakar and Satish Chandra, there are very interesting, but few minutes, so maybe a couple of questions you can take, one each to each.
Am I audible?
Yes, sir. So please unmute your mic, sir. Dr. Satish, sir.
You are mute.
Yeah. Am I audible?
Yeah, Prabhakar.
Yes, sir.
Yes, sir.
Yes. Yes, I'm Dr. Satish Chandra here, and there are about 20 questions there in the box, but I think I should summarize some of them rather than going into the details because of want of time. The two basic questions which comes up are, one is the legal aspects of it. So what is the legal status in telemedicine? Whether can it be stood by the legal matters? That is number one. And the second question is the payment mode. The payment mode is the question which everybody is asking, how it can be done, whether is it feasible, or what are the problems which you face. I think one of the speakers can take it up. I think Lakshmi, can I ask you to answer these questions?
Yes, sir. So regarding the payment mode, there are two kinds of things. One is where you can ask the provider that there are a lot of platforms which are available. The one model which is operating right now is 10% goes to the provider, which we rent you the model for each consult for the platform. 10% of your fee they will take, and then the rest of the amount will come to you. They have the payment interface inbuilt in their platform, which you can use. Second thing is, among these platforms, you must verify whether they are HIPAA compliant, which is Health Information Privacy Protection Act, which are version number 2 compliant. You must ensure that your platform is HIPAA 2 compliant, so that they have the privacy. They don't, whatever information which happens, it should not leak out, because sometimes you may have to consult VIPs or celebrities. Second question is regarding legality. The Government of India, Ministry of Health and Family Affairs, have cleared the post-COVID era that these, with a disclaimer and with an exception of certain drugs, you can prescribe this with adding your disclaimer that this is there is a sentence. Every format is given in the Ministry of Family Affairs. They can look at the guidelines which was shared by one of the speakers. The same guidelines talks about the prescription guidelines and your responsibilities. The Government of India has allowed it now, right now. Thank you.
Can I make a comment, sir?
Yes, sir.
Yes, go ahead.
Yeah, so what our group has done is that we have hired 2 independent agencies and paid them upfront as hiring us as consultants to them. That is one aspect of video consultation which we do. Second is through our hospital-based app. And third is independent web consultations of each one of us. So in the first module, the payment goes to the hospital. They pay us on the end of the month a particular percentage, which has been pre-agreed by them and us when we had a contract. The second is that they don't take any fees extra. They pay us everything when we are on those platforms. The third is the individual one, which we have created. So in that, what I have done is that I have made myself available as a Paytm businessman, and the Paytm has created a QR code for me, which I have generated as my digital picture on my WhatsApp. And I have made an artwork which I exchange with anybody who wants to have my video consultation, which clearly mentions that if you want to have an audio consult, usually for follow-up patients, if you want to have a video consult, usually for new patients and some old patients with new symptoms, charges are different. 500 say for 5 minutes, 800 for 10 minutes for audio consult, 1500 for 10 minutes of video consult, and 20 minutes video consult would be 2000 rupees. So in that way, the patients can decide which platform they have to choose to pay. As far as the legality is concerned, what I do is this. So I give them a prescription in which I write very clearly that it was a video-based consult. This is the probable diagnosis. These are the suggested medications. These are not the medicine which I prescribe. This I'm only suggesting, and the patient is free to take or not take them. And finally, at the lower end, I write not fit for medical purposes, medical legal purposes.
Yes, thank you, Sumit.
Okay, can I say something?
Prabhakar,
Yeah.
can you take up other questions?
Yeah. Before taking the question, I would like to say that the medical legal aspect is not that easy, because in the Fortis Hospital, they have made a disclaimer of 6 points. And that disclaimer I can put on the mail, and that disclaimer is very good, because it involves you about everything, and everything you cannot explain to the patient when you're writing the prescription. So a disclaimer has to be done, and it is a partially legally advised disclaimer, which it is given in the prescription. Like this is the prescription, the last 6 lines are the disclaimer which are there. So that is one part. The other thing is there was the payment. The payment one, I either do UPI or they directly transfer to my bank account.
Exactly.
So that is one. Now, any specific questions which I don't have in the box, my questions.
There are questions are there.
You ask the question.
There is a question.
Can I ask one question, Doctor?
I think there are some questions are there.
Dr. Prabhakar, can I ask you one question?
Yes.
Do you take payment beforehand giving the consultation, or you take payment after the consultation?
No consultation without payment.
No consultation.
Absolutely, sir. Absolutely.
I'm doing through the Apollo Hospital, and they have 24/7, and that is done through the Apollo Hospital app, and payment is made before. Yeah, there are some questions to Sumit regarding the somatosensory and motor examination. How easy or how difficult it is to do, and is it possible? That is what the question is. Sumit?
I have already told most of this answer is already there. There is also one question in which they have asked the studies. So there are 3 studies which have been done: the feasibility study, the user satisfaction study, and the efficacy study. So I'm sharing my screen for 10 seconds to show you these 3 studies. And so this is is the PowerPoint visible?
Yes. Yes, it is visible.
Okay, so there are 2 studies from Ireland having 25 patients each. And these patients were evaluated for their feasibility, whether it was possible to be done. Most of the people who participated in the study, the doctors as well as the paramedical staff, felt that it was possible. the satisfaction was that the level of satisfaction was good, and only 4 out of 25 patients felt that they were dissatisfied. All the paramedical staff, all the doctors felt that they were satisfied. And then this efficacy in which 128 patients were randomized to be treated routinely by general physicians with neurological symptoms, and other 128 which were randomized to receive a teleconsult in which a doctor examined the patient at the hospital and a distant neurologist gave the instructions. The primary endpoints were the discharge days. So the number of stay in the hospital was significantly less in those where a video consult was offered by a distant neurologist.
Thank you, Sumit.
Sumit, can I add one thing? Sumit,
sir,
you said very rightly that if there's a doctor, then it becomes easier. But during this lockdown period, it is the relation which really tries to help. Many times they are not able to elicit the reflexes even to their whenever you try to explain.
Absolutely, sir. We can only have a very rudimentary, basic.
Sensory is also difficult.
I think
absolutely, I agree with you completely.
Follow up is okay.
Yeah, I think I'll go on to the one more question which is very important. People are asking about the medicines which we can prescribe, especially psychotropic drugs and SSRIs and other AEDs, gabapentins. There was a question regarding this. Can we prescribe this? Can Lakshmi Narasimhan can take it up?
They have listed the narcotic schedule H drugs cannot be prescribed, sir. There is a list of things which is there in the I can locate that and send it to you, sir. I think that I read it in the MOS recommendations on teleconsult.
Can I ask one thing, Lakshmi? Dr. Lakshmi,
Yes,
can I ask you one thing? What do you do to your patients who are already on these medicines? They are coming a follow-up. They can't get these medicines without...
Sir, for the new patients, the follow-up patients already whom you have completed complete physical examination by you, refill of the prescription is allowed, sir.
Yeah,
refill is allowed.
Yeah,
refill is allowed.
Now refill is allowed for most of the anti-epileptic drugs and some of the benzodiazepine preparation.
Yes, sir.
There is a guideline issued by the Ministry of Health, but only thing is with the signature you have to write your registration number, which is extremely important.
Yes, sir.
Which is extremely important.
Dr. Satish, you have said the right thing. The registration number is very important.
Yes.
That should be, prescription should be downloaded and it has to be prescribed, and the amount of dates have to be given, how many days you are prescribing.
Yes, very clear, very clear. It has to be.
You put a seal that do not, also put a seal that do not substitute or do not extend the prescription. No extended refill should be there.
Dr. Lakshmi, a new thing has come, which is, as you know, in lockdown period, now many people are being sent. Those who've been retained there, they are going back. 2 of my patients have approached that they are want to go back to Ranchi, to their home place. They were stuck in this lockdown period. They wanted a certificate that they came for to show me, and they got lockdown here. And they wanted a certificate. The government says that you have to be tested for COVID, and then on that certificate, you and your family can travel because they are crossing daily border to another state. So that has come again. So I have been given that certificate with my stamp and forwarding it.
I think there are a lot of problems from that point of view.
Public health will take care of that, sir.
I think there are a lot of problems with that. We don't want to get into that. I think just to say 2 other things. One of the very important, everybody has appreciated this initiative by the IAN. And I don't think we have time to take it further questions, isn't it, Dr.
No,
Nirmal?
I think we are over 45 minutes. We really need.
Can I just?
I
think you should summarize it, Nirmal. We'll say that.
Sudesh, you want to say something before I take over?
I think it was a very good meeting, and IAN has to be complimented for taking up such an important aspect, and all of us are very much interested in that. One of the requests which have been made by many of the people are that you should send the guidelines. You can circulate the guidelines through the email. I think there is a MHA which has already given the tele guidelines. IAN can do that job. I think that would help a lot of the people. Thank you very much.
Guideline will be available on website, sir. It is available in IMA guidelines are very much there. That's the reason we did not bring guidelines, because guidelines probably is there for last 3 weeks. Everybody knows it. Dr. Prabha, last word from you before I take over.
Yeah, it has been a very interesting talk by all the people, and all the matters have been raised. We have to be very careful, and we don't have to worry. The people are in the habit of asking consultation on the telephone, and it is not right. I think we tell them that it is legally you cannot prescribe any medicine on telephone, and if they want to get a written prescription, they have to pay. That's the easiest way to tell to those people.
I'm glad you are back to
Thank you,
practice.
sir. Thank you very much. And before I close the session, I want to thank all the speaker and chairperson. I have got 2 announcements to be made. One is IN can provide a TeleNeurology platform to all the members. What I will do is I'm going to send an email with a Google form with questionnaire. If people are agreed, then IN can make a platform for TeleNeurology consultation with the payment collection. Will formulate how we can do it. Bhavesh can help us out on the platform. So we'll send you a questionnaire on Google. If the people, more than 200, 250 people are ready to accept that, then we'll work on that and give them a platform which could be easy, handy, and straightforward for them. Number 2 is IAN has announced a special award for people, youngsters who can come out with a quiz sort of thing of a neurological examination through the TeleNeurology. So if they send a short video of a particular examination and showing certain sign or some syndrome, that they upload onto the IN website, and the best one will get a prize which will be decided by the IN executive committee. So these are the 2 initiatives which the TeleNeurology has done already. The subsection already will start. So those who are ready, they can join with Dheeraj. With that, I thank you very much for overwhelming response and taking participation in this. I don't think it is end of year. There are so many issues which have opened, and there are so many issues which will continue. So maybe in coming weeks, if we can come out with a 3-hour symposium on TeleNeurology where people can present their abstract to us, and we can have a continuous presentation. Dheeraj, you can take it, and all the panelists here can take it. Then we can have a dedicated sort of a half-day workshop on TeleNeurology. With that, I say thank you very much, and for the have a nice lunch and a nice evening. Thank you.
Thank you, sir. Thank you very much.
When you
Thank
want
you
to
for the
say something,
opportunity.
my secretary would like to say last word. Dr. Gagandeep, unmute your mic, please.
Anything too much because it's already lunchtime, but thank you. Wonderfully conducted, Nirmal, all the speakers, the chairpersons, the panelists. Excellent. We will certainly take it forwards. And thank you very much. Thank you very much. Okay.
Thank you, sir. Have a good day, all of you, and
Thank you.
stay
Bye.
safe.
Thank you. Thanks.
Thank you, sir.
Pleasure.